Okay, so now we're going to go through Chapter 40, Assisting in Pediatrics. And like gynecology, it does tend to overlap with family practice. You could decide to go into pediatrics solo and deal with, kids that are newborns to 18. But if you're in a family practice setting, you'll see a certain degree, 20 to 30% of your clientele is going to be pediatrics. So even if you don't wind up in pediatrics, family practice still has its share of pediatric patients. So being familiar with this chapter and some of the things that go along with this chapter are important. Okay. So looking at some of the outcomes that we'll look at, the first part of this chapter talks about growth and development. And as far as the different age groups of pediatric patients go, so we'll go through that first and try to talk about the medical assistant's role during the pediatric exams. Definitely immunizations is a huge role of the medical assistant, knowing the schedule and how to do a late start, and be an advocate for the patients and the parents, and making sure that they are fully aware of what the immunizations are, and just familiar with all the information that revolves around them is important. I included the 2018 immunization sheet on Canvas, so it is there. I think you can print it up from the file that I put it on, so it's not the updated one from 2019, but it's got pretty much the normal run-of-the-mill schedule that you would be dealing with in a pediatric setting. Okay, we'll talk about some of the variations on the pediatric screening procedures and some of the diagnostic testings that are routinely done. And then at the end of the chapter, it goes through some of the common pediatric diseases and then some that are a little bit less common, and then some special health concerns that we need to look at when we're dealing with peds patients. So when we look at pediatrics, it is a specialty area. It is the healthcare of children, and pediatricians are the specialists that take care of children. And so it's important that they monitor the development and then diagnose and treat any appropriate conditions that might present themselves. Okay, so vital sign accuracy is huge because we're dealing with children that are growing rapidly, and certain diagnoses like failure to thrive and different thyroid and endocrine conditions can be made off of looking, at least initially, by vital signs. And so if somebody's not documenting the growth right, whether it's the height, weight, or the head circumference, and if we diagnose, if it's not done correctly and it looks like everything is normal, things won't get diagnosed. Or if it's done incorrectly, it might cause children to undergo tests that they don't need to. So accuracy of this is important, and so it takes time and practice, but be very proficient and confident when you do your vital signs because it's really essential in this age group. Okay. So you're looking at the medical assistant responsibilities. It's a lot because you're seeing the patient from start to finish. Not only are you dealing with the patient, the pediatric patient, but you're dealing with the caregiver as well. And so you will be providing a tremendous amount of parent education regarding safety and normal growth and development, immunizations, different lab tests that might be done depending on the scenario. And so there's a lot that needs to be done. And so it's important to develop a really good relationship with not only the patient, but the caregiver as well, okay? Adhering to immunization schedules is big because when kids get behind, it's really hard to catch up. And so making sure that the parents bring their immunization record to every visit is important. And I would dare to say that 25 to 30% of the visits the parents forget. And it happens because they get locked away, especially when they're only seeing them once a year. Usually when they're earlier on, it's not as bad. But it's really important that you have them, that everything's documented, so that if that patient goes someplace else, they don't have to restart everything over again. So adhering to those immunization schedules are huge, okay? And although as a medical assistant, you're not diagnosing anything in particular, it's still important for you because you're going to spend a lot of time with both the patient and the caregiver. And so there may be things that come out in the interview that maybe the clinician might not pick up on. So any kind of health concerns that you see, anything out of the ordinary, anything that might relate to abuse, or some of the things we'll talk about at the end of the chapter, is important to bring up, okay? Because you want to make sure that we're covering all bases. We want to make sure that, the clinician doesn't miss anything, okay? And so really and truly, the medical assistant is a total advocate and liaison between the parent and the child and the parent and the physician. Okay, all three together, working together. Okay. So the first part of this chapter kind of goes through and lists different age groups, and then kind of lists these developmental milestones for each age. We have physical development, the intellectual slash cognitive development, psycho-emotional development, and then social development. So this book kind of divides these areas. When you go through each age group, and as a medical assistant, there will be certain screening or questions, developmental milestone questions for each of these areas that will be asked. And you're not going to have to remember them off the top of your head, but they will be listed. And so part of the medical assistant's job with not only taking vital signs and doing everything is to either question the parent, the child, or just the child, depending on how old they are as far as some of these questions. And they're listed and they go by age, and it really just kind of gives an overall view to make sure the child is developing normally compared to his peers. So we'll start out and go with a neonate. So this is going to be kind of broken up into 5 or 6 different areas as far as staging of age. So the neonate is considered birth to 1 month. Okay. The physical development, the head is quite large. It's about 1/4 of the length. And so it's not uncommon to have those dimensions. And so that's one of the reasons why keeping the head covered, at least early on, is important, why they send the child home with a little hat, because they can lose a lot of heat through the head. And so that's why a lot of them will wear a cap for the first few weeks to a month because of this enlarged head. And it does eventually even out, but initially it is about 1/4 of the length. The skull has to move easily to get through the birth canal. And so the sutures of the skull, the cranial bones, are not fused. And so you have an area called a fontanelle, which is sort of a soft spot. There's an anterior one and a posterior one, and the anterior one tends to be a little bit larger. And so that basically allows for the brain to grow. And so usually within about 2 years, the fontanelles will seal off and they'll close, and the sutures will fuse, and you won't notice the soft spots anymore. But it is noticeable sometimes in some kids, and it can be a diagnostic tool. If one of them is bulging, it might indicate that somebody's got a hydrocephalus or a condition going on in the brain. So we can use it as a diagnostic tool if something's abnormal with it. The skin of these babies tends to be very loose and wrinkled. They can be kind of on the erythematous side, and they usually will peel for a few days to a week. The umbilical cord stump usually falls off in about 10 days. It does vary from child to child, and just a little bit of alcohol with a Q-tip can be put on there. It's not necessary, but sometimes that will dry it out a little bit quicker. Jaundice is a situation that is kind of frequent. Some cases are more serious than others, but jaundice is basically a yellowish color of the skin, and it's due to as the red blood cells are breaking down within the baby from the birth and what have you, because the liver is immature. As the red blood cells are destroyed, bilirubin is what's released, and so when the bilirubin gets a little bit high and it takes the liver a little bit of time to get rid of that, it can cause the skin to turn yellow. And so one of the most important things for that is just to make sure the babies stay hydrated. Sometimes they'll give them a little bit of water, an ounce or two of water, but just making sure that they stay hydrated with breast milk preferably, but even formula is probably the most common treatment. Some need to have UV light or a billy blanket, and that does happen depending on the severity of the case. But it can be toxic, and it can cause brain damage if the bilirubin levels get too high. So it's definitely important to make sure that these children are watched carefully. They'll usually have heel sticks done daily to monitor the bili level to make sure that it comes down. The neonates tend to have very prominent reflexes, and there's some reflexes that occur just in the neonates and the infants, and then eventually go away as sort of the startle reflex and something called the Moro reflex, or reflexes that we just see in the neonate. But that indicates that everything's neurologically intact and correct with the neonate. So pediatricians are looking for those reflexes when they do a physical exam. And although vision and hearing, the stages vary. They don't have the same visual hearing that you would deal with in the older sector, but they still can. There is still a certain point where the babies can start to see, and then they should have hearing and startling reflexes. And so if they don't have any there's a hearing issue, then some of the reflexes might be altered as well. So it's important to assess for these even in the early stages of neonate and infant time. The intellectual and cognitive development, basically the thing that's important or kind of reflects around that is that when they're held, they're usually calm. If they've got colic, they might not be, but most of the time when they're held and when they're picked up and held firmly, they usually calm down to where sometimes if they're not, they tend to feel insecure and they'll cry more. Social development, the babies respond to stimulation. They do establish a little bit of an activity pattern. They do respond generally to soft, gentle voices. They will try to focus on the face, and that's when they can, you know, that their vision is actually at least there and they're seeing. They can show excitement, distress, and so there is a social development pattern that can be developed even at a neonate stage. When you're looking at aspects of care, you want to make sure that you don't have to give them full submergible baths when they're at this stage. Just tepid sponge baths work. No lotions and powders and lotions and oils are not needed. I've known parents that like their babies to be shiny and they'll put baby oil on them and then their pores get clogged and then they come in with a folliculitis. And so they don't really have to have any lotions or oils or powders, just the tepid sponge bath. Is generally all they need till they're a little bit older when they can actually get a little bit more submergible in a bathtub. Feeding is going to vary a little from child to child. Usually they're going to have 1 to 2 ounces every 1 to 2 hours or 2 to 3 ounces every 2 to 3 hours. Breastfeeding on demand pretty much goes, most of the time you're going to breastfeed for about 10 to 15 minutes per breast, about on demand is what they say, but prototypically it's every 2 to 3 hours. You can kind of measure whether or not they're eating well enough by their wet diapers. Most babies should have 5 to 6 fairly decent wet diapers a day. If it's more or less, then, especially if it's less, that would be indicating that they're not getting enough. So that's generally how you can tell whether or not those babies are getting enough to eat. Okay, so when you actually hit the infant is considered 1 month to 1 year. There's a huge amount of growth that goes on in this time frame. They are developing from head to foot. The larger muscles do develop before the smaller muscles, so they do tend to get stronger with the larger ones before they develop the fine motor skills with the smaller ones. But their eye-hand coordination or hand-eye coordination does tend to start to develop at this stage, where they, by the time they're 4 to 6 months, if they're on the floor, they can pincer grasp and start to pick up small little toys or little things that are in the carpet. And so being very, very careful with what is left around is extremely important. They can, by the time they're 12 months, start to follow simple directions. Go get your bottle, go get your cup, come here. So there's a number of small commands that they can start to understand in that time frame. Addressing the psycho-emotional development is important. You have to address their physical needs quickly and calmly, and contact and cuddling are very important. They tend to, by 8 to 9 months, they'll get separation anxiety when the caregiver that they're with the most leaves or isn't visible, and so that's very common to develop that nervousness over that. Social development occurs very quickly within that first year. They're waving, they're smiling, they're responding to interaction, they're transferring toys, they're picking things up, and so there's a huge social development that occurs in that time frame. Although they really do respond mostly to their caregivers the most, that are who they respond mostly to. Aspects of care, the regular checkups are important. Generally, we'll talk about this a little bit later, but generally in the first year, the book says 7 physicals or 7 exams. I kind of prototypically worked with 6, and we'll talk about that scheduling. But keeping the immunizations on task are important because if they get behind, it can be difficult to catch up, and then you're having to do a lot of sticks in a closer time frame. And so you always want to make sure that try to keep those parents on a strict schedule. Okay. Prototypically, they will, you want to encourage breastfeeding for the first year or even a little beyond. You only you can use bottles up until 12 months, but they do recommend trying to wean from bottles at around 12 months. The longer you let them bottle feed or stay on a bottle, it can be harder to get them off. Same thing with breastfeeding. You don't want cow's milk or whole milk until 12 months, and you're going to always introduce solids one at a time. Usually about 6 months or so, you can start introducing baby foods. Prototypically, they recommend veggies first and then fruits, and you want to do every 2 to 3 days before you introduce a new food in case there's a food allergy. Toddlers, these are the fun years, 1 to 3 years. These are lots of trial and errors of things go on in this time frame. It is a lot of fun, but it can be very challenging because they are very busy and they are into everything, okay? We're at a point where that first year we saw a tremendous amount of physical growth, weight gain, and height. Here things start to slow down a little bit. When they were infant, the body grew first, and then the arms kind of lagged behind. And here we actually start to get arms and legs lengthening. Generally by 15 months, they start to walk. Most kids can walk a little earlier, but 15 is kind of the cutoff. If a child's not walking by 15 months, they'll generally start to look in them some sort of muscular issue or some sort of reason as to why they're not walking. The hope would be that the kids are toilet trained by the age of 3. It doesn't always work that way. A lot of times they're daytime potty trained, but the nighttime comes later. Some are trained earlier, but prototypically you're shooting for 3, 3.5, or 4 when that actually happens. They do learn a lot through play, and so it's important to let them pretend play with dishes and toys that bring out that creativity. They do start developing an independence at this stage, and we definitely get a lot of speech progression here. They have about 900 words when they're 2 to 3, and that goes to like something in the realm of 5,000 when they're 5. So there's a huge speech development at this stage as well. Okay. Psycho-emotional, they start to gain some control over their expressions. They do need consistent limits. And this is where I think it gets very difficult with parents. I used to watch the show The Nanny, and they when parents don't control limits or set limits and are consistent with them, then the kids can get out of control. And so consistency here is absolute paramount. As difficult and as tiring as it is, it's really important for the parents to be consistent, because if it's not, the kids will push limits because they don't know, they know they can, and until someone actually says, nope, you can't do that, they're going to push it. And so it's important to do that with meals, with play, with bedtime, with all aspects of life really should be on a consistent schedule. They do start becoming more sensitive to feelings of others. When they're younger, they don't notice it as much, but here they are starting to kind of step outside the box and see feelings of other individuals, both family and their friends. Okay. Sharing is always a tough one, and I think this is this stage in the game, they're starting to share, but some share better than others. And so encouraging that, and even having time where the parent and the child, share, oh, I'll hold it for a little bit. Okay, thank you. And then hand it back, and really mimicking and doing role play with this tries to help guide the children, because they tend to be very possessive of their own things or anything that they're holding. So if they can learn that at a young age with interaction with either their own kids or peers or their siblings, is important. And obviously adults can try to help to guide and learn the appropriate behavior, because sharing is probably one of the most difficult things they have to go through and learn. It's really important to promote and really encourage fine motor skills as well as language skills as well. And this will vary. Some kids have fine motor skills very early, where they can use a pencil much earlier and their language is much more advanced, and other kids kind of lag behind a little bit. And so it's just important to always promote it. Make sure the parents understand the importance of reading to the children, even if the children can't read. Letting them draw, work with blocks, Legos that are appropriate for their age. Anything that promotes that fine motor activity and language skills is important, because that will help aid them later on as they enter school age years. When we deal with the preschoolers, we're dealing with 3 to 5, and so the growth rates will vary here. Sometimes you'll have some very large kids, and other times they're a little bit shorter. And so those growth rates do vary a little bit. Okay. This is where vital sign-wise things start to slow down a little bit. In the beginning, the heart rate of the neonates, the infants, and the toddlers tend to be a little bit faster. Respiratory rates are a little faster, and we talked about that chart in chapter 37. And so just kind of noting that that will start to happen. Calcium is huge here because they are growing quickly. There's a lot of bone placement that's going on. So calcium is really important. I know a lot of people some people like to advocate milk, others don't. But calcium, leafy green vegetables, certain dairy products, even if it's yogurt, cheese, that calcium intake is really important because the bones are constantly forming. By this time, they're starting to develop nighttime continence where they can actually be potty trained. And usually by 3 to 4, they are during the day, but occasionally they'll have nighttime issues. And so this is about the time where things are starting to develop as far as being able to control their bladder at night. Fine motor skills are starting to really develop here. They're starting to use a pencil. Some of them can jump up and down on one foot. They can start to ride a bicycle sometimes at 4 to 5. And so we start getting some of these motor skills that are developing. And so doing things that encourage the fine motor skills are important. Finding the toys or activities that promote that are important so that they can develop in a normal pace. Intellectually, I think I said this before, the vocabulary at 3 is about 900 words, but at 5 it hits, here I think I said 5,000, it's 2,000 words. So we have a pretty big explosion of words as far as this age go. And some people will say that you have your entire vocabulary by the age of 5. I suppose that does qualify for some people, but what it shows is there's a huge cognitive development in that stage. So making sure that they are exposed to appropriate words and words that are, reading books. Even if they can't read, sometimes just encouraging them to tell the story after you've read, after someone's read to them is important. Psycho-emotional development. These are an area where you actually can start to give these kids some light chores. That's why a schedule of things that are appropriate for their age, taking out maybe the trash, picking up, if they've got an animal, picking up dog messes, little things they can maybe let them back, sweep, just little things where they can feel like they're helping around the house. If you can get them used to doing, where they can actually get used to doing a few things so that as you hit the teenage years, they're used to doing things. When you try to get the teenagers to start doing things, they kind of tend to resist. And so if you get them started at a young age, it tends to make it easier as they get older, okay? They start to be able to take turns. And so this is where they're a little bit, the sharing tends to kick in where they can accommodate that a little bit more. And they are able to play and take with other kids. And they usually will start to enjoy when they hit 4 to 5. They really do interact and share and role play quite well with each other. This is an age bracket, though, where nighttime routine is huge. And if the nighttime routine gets messed up, it can make sleeping or going to sleep very, very difficult. And so this is where establishing a same routine, something that they enjoy, usually eating, bath time, reading time, maybe a game time or whatever, and then something to settle them down and to go to sleep and to make sure that everything is routine, night lights, making them feel, comfortable at night, making sure they feel safe. But those nighttime routines are essential because parents that don't have nighttime routines, they tend to have kids sleeping with them. They don't want to go to sleep. It takes them hours to go to sleep, and then the parents are exhausted. So this is another part of the developmental information that parents need to realize is how important these nighttime routines are. Elementary school kids, this is 6 to 10, first grade to maybe fourth grade. This is where we start to get the physical development starts to be a little bit different. Girls tend to grow a little bit quicker for the most part compared to boys. Muscles are continuing to develop. They do need to start into some regular exercise here. So starting a sport, sometimes at this stage in the game, soccer or baseball or, martial arts, something where they're getting some regular exercise. is good because you want to start to set those patterns so that when they hit middle and high school, they're used to doing physical activity. We do see a bit of a attention span increase here. They start to be able to separate fantasy from reality and start developing that sense of right and wrong, to where when they're 4 and 5, they do tend to, sometimes they'll lie and stretch the truth. They haven't quite figured out the difference between fantasy and reality, and so they don't quite understand the difference between the lie and the truth. Here we start seeing that development start to occur at this age bracket. Peer influences become really important. They start kind of start sliding into gender related roles. Very, very sensitive to criticism. So you have to be careful how you talk with these kids and how you, especially if you're upset with them or if they've done something wrong. It's important to be consistent and discuss it, but be very, very careful how things are described, because they can get quite emotional and sensitive to certain things that are said, sometimes even more than you might think. You might think, well, I was very nice, but they still kind of took it the wrong way. So it's important to make sure that the proper words are used and the proper tone is used. Okay. Socially, we don't want to overwhelm the kids at this stage. They need lots of outdoor activities and camping, and not sitting in front of the TV and sitting in front of video games, because then they become so used to that constant visual stimulation. Then when they have to go outside, they don't know what to do. So that's why getting them involved in some sort of sport. Music is a good thing to start at this age too, but not overwhelming the child with too much, because some kids can handle more than others, but if they're overwhelmed, it'll be difficult for them to, they won't be able, you'll start to see that stress in other areas, and so you don't want to do too much. Okay. As it was for the 3 to 5-year-old, structure and schedule is very important. Making sure that a big calendar is available so the kids know exactly what they need to do, when they need to do it, helps make them feel secure. Kids tend to act out a little bit more when they're afraid or unsure or just kind of stressed in general. And so making sure that a structured schedule is set and kept to adhere to as much as possible will help to create safety and make them feel secure in their activities. Consistency with things as well as discipline is important, just like it is with a 3 to 5-year-old. You want to make sure that things are consistent with these kids. They have a schedule so that they know what to expect. You get better behavior when they have consistency in their life. Got to make sure they're getting their health and dental checks. These are pretty much yearly at this point. Dental checks are usually every 6 months. You want to get your physicals done every year, even if they're not due for shots. And there are some age groups that aren't. You still want to make sure that they're going in every year and getting it done to make sure that at least their height, weight, and all their other vital signs are, and their growth pattern is normal for that age. Middle school is 11 to 13. This is quite turbulent. We had kind of calming and growing ages in the elementary school. Then we get to middle school, things get a little turbulent, not with all kids, but with some. Girls start going through puberty a little bit earlier than boys, 11 to 13, give or take. Boys are sometimes 14 to 16 before they start going through puberty. Skin problems love to show themselves at this point, so proper skin care is important. Facial washing twice a day is huge. A lot of the dermatologists will recommend like a Cetaphil cleanser in the morning with some sort of benzoyl peroxide at night, and really being diligent with that, because kids that have acne issues, sometimes they need more than that, but that's a really good place to start. If things start getting bad, you want to get them into the dermatologist so they can get them on the proper treatment regimen, but most dermatologists will recommend that twice daily cleansing with those two types of products to help out with the acne and skin problems. This is where sometimes the grades will start to slip. The kids get a little bit hung up on their hormones, and things are rapidly changing in their bodies. They're going through puberty, and so sometimes you'll find some kids tend to have grades slip. They tend to exaggerate a little bit. They really, really want to be independent, but they're really, really afraid. They can be temperamental. They'll kind of, whatever their peers are doing, they'll start doing the same thing. So there's a lot of trying to discover themselves at this point. And so you'll see a lot of mimicking and following. And so it's important to really help these kids realize that they need to be themselves and not necessarily following what other people do. But it can be a rough, turbulent time with puberty going on at this stage. Relationships are huge here. They're really starting to develop friends that they may have for a long period of time. They really do look up to adults, even though they sometimes will criticize and make fun of adults. They really do need somebody that they trust to talk to, because there's usually lots of questions, lots of puberty questions, lots of sexual questions going on here. So having an adult that they can talk to that's not going to judge them or get mad at them is really important, because they need to be able to be open and keep the communication lines going. So aspects of care is just to make sure that child realizes they are valued and loved. Discipline still here. I think this is going to be something we see through the whole aspect of age, but discipline has to be consistent here too, because kids will start to push limits here. They'll start to, take off. They have a little bit more independence here, and so sometimes after school they'll take off and go with their friends. And so it's really important. You want to keep those communication lines open so the kids will continue to talk. Don't be hypercritical. It's very easy for parents to criticize and be overly critical of kids. And so it's important not to do that. You want to maintain a good, open communication lines. Make sure you monitor friendships. Make sure that you're aware of the friends, and don't overschedule their time too much. They do need to have activities. Kids that have regular activities in their lives tend to stay out of trouble. When they have too much free time, sometimes that can be a reason why kids end up getting themselves into trouble. But you don't want to overschedule them too much. They need some time to just be kids and relax too. 14 to 19 is our high school years, and so generally at this point things calm down a little bit. Most of the girls have already gone through puberty, although this is the stage where boys are kind of starting to go through puberty, 14, 15, 16. So then we start to have the boys start to catch up in size. And so there's a lot of physical development going on. Healthy habits are important to start young, because they start hitting the teenage years. This is where they start skipping meals and they start eating candy bars and potato chips for lunch with sodas. And so it's important to start healthy eating habits early, as far as regular exercise too, because this is where they start getting a little bit more into what's going on with their friends and their social life, and they sometimes will abandon some of the other things they learned as a kid. So you want to make sure they have good eating habits, good exercise habits, healthy sleeping habits, so that it'll help keep them a little bit more steady in their social relationships, as well as when they're in school too. Okay. They will start to develop their own values here. They don't always see, they start to have their own opinions about things. Where when they were kids, they would kind of either adopt what their friends liked, or even with their parents, they kind of would take that on. And then here they start having a little bit more independence, developing their own values and their own thoughts. However, they don't always see the consequences of behavior. And this is why we sometimes see that stupid behavior that teens do. Everybody will look back going, yeah, that was kind of stupid. I don't know why I did that. So occasionally there's a little bit of a blunting of things. And so we'll just not look ahead, and we don't always see outside the box. And so that is kind of common, especially for the 14, 15-year-olds, where they just don't always see the consequences of their behavior. So once again, having open lines of communication are important, so that the kids have an adult that they trust to talk to. So sometimes the pressure of adolescence in of itself can lead to anger outbursts, and this is where we start to sometimes see anxiety and depression, eating disorders, violence, gang membership. All of that kind of stuff can start to happen here, because there's a lot of pressure from peers in school. And so even though you would think that when they come in for a physical exam that we're just dealing with their physicality of things, we have to look at the emotional development as well. Okay. Socially, friendships are huge here. They really will start to develop lifelong friendships here. Not everyone will keep their friendships from high school, but at the time it seems like these are going to be their friends forever. And so everything that their friends say is gold. And so sometimes this is where friends' influences are more important than parents. And so just once again, making sure that parents realize they have to keep open communication and still setting guidelines. We can't let them go just because they're in high school. they still need to have structure, and they still need to have particular discipline and consequences if they do something they're not supposed to do. So the other thing, we're looking at aspects of care. This is where we have to make sure they start, if they're in the public health, or if they're in the public school system, they will get they'll get sex education, usually 6th, 8th, and 10th grade, I think. And so if the child's in a private school or in like a homeschooling situation, that may not happen. So it's important to make sure that the kids are at least, that sexual activity is discussed with them. They need to know the consequences of having sex without some sort of protection, and also realize that there can be infection consequences if they don't. And so it's important for them to know that. Some parents still like to hide all of those things from kids, but prototypically it's better to inform them so that they are aware rather than keep them in the dark. Okay, so we kind of went through the stages of development. That was just kind of a quick recap. There's a little bit more information listed in the sections in the book, but that was just kind of a brief overview. Now they kind of break it down and talk about the examinations themselves. And so once again, when they come in for their pediatric exams, each age group will have a certain set of questions revolving around just the areas that we kind of talked about to make sure that that child is developmentally online for peer, as the peers their age. And so there will be questions that need to be asked every single exam when that child comes in. And generally the medical assistant will ask that. And if there are questions that are not being met, then the physician would take a look at it and decide whether or not something needs to be done. But just going through the motion, going through and making sure that those questions are asked is important. Okay. In the beginning, when you have these exams, you'll initially be talking, obviously, when the patients are very young, when they're infants and toddlers, you'll kind of address the parent. But as the child starts to develop some language, you want to make sure that you're addressing the child and the parent. So you'd ask the child something, and then you'd ask the parent for backup. Then you'd ask the child, and then you'd go to the parent. And as the child gets older, you'll address the child more and the parent a little bit less, and only go to the parent if necessary. So it's important to address the child and not just ignore the child and talk to the parent solely, unless you have an infant that can't communicate. But when you start having the older kids, it's important to do that. Anxiety is a huge issue. Anxiety over the dentist and anxiety over going to the doctor's office is huge. They think every time they go, they're going to get a shot. And sometimes that happens, especially early on. But they need to realize that it's important. Immunizations are there to keep them healthy and to protect them from diseases, and not a bad thing. And so relieving their fears, not lying to them. Don't say, oh, no, you're not getting a shot, and then have to give them a shot. You want to be upfront with them. Sometimes trying to, divert the question, if they're coming in and they would say, do I have to get a shot? Do I have to get a shot? It's like, well, we'll talk about that in a little bit, but let's do these other things first. Always try to get everything out of the way and then deal with it. But you don't want to lie to them. You don't have to tell them, oh, no, we're not going to do that, and then do it. Okay. So you want to explain everything that you're going to do. And when you have a younger child, you can allow them to examine the instruments. I always let them touch my stethoscope. I make sure I clean it afterwards, but let them kind of check that. I'll let them listen to my heart, and then I'll listen to theirs, and I'll let them look in my ear, and then I'll look in theirs. So blunt instruments that aren't going to hurt them are good, because then they feel comfortable. They know it's not going to hurt them, and they tend to like to do that. So it takes a little bit longer, but doing that starts to alleviate a little bit of the fear. Okay, and you always want to speak in terms that are appropriate to their age level. Don't talk over them, but don't talk under them either. So prototypically, the first year when we're dealing with infants, the book says that they do 7 well baby exams in the first year. We functioned and did 6. You can do 7. Usually you'll do a visit within the first week or so after the baby is born. And then you do a 1 month, 2 month, 4, 6, 9, and then a 12-month or 1 year. So that's 7. There are some places that will bypass the 1 month. Not everyone does that one. There's no shots given at 1 month. And so some places, after they've seen the baby, 2 weeks after it's born, they'll say, we'll see you in 2 months, unless there's an issue. So there might be a case scenario if they're following something or they're concerned that something isn't normal, they might do a 1 month. So the 1 month is there, but it isn't done all the time. So for the sake of the book says 7, and that's what's listed here. But there are certain cases where if they're going to bypass one of the visits, sometimes the one they might bypass if everything's going normally would be the 1 month. Shots generally start at 2 months, and then you have shots 2, 4, 6, and 12. The 9-month visit sometimes has shots. Usually there's a hemoglobin done there to make sure the child isn't anemic. And the first shot is usually the hepatitis B vaccine given the day after birth. When we go to the second year, they usually will do a 15 and 18 month, and then a 24 and 30. So we do 3 months for that first between 1 and 2, and then they'll go to 6-month visits. After that, you'll go annually every year after 3. And so it's just really important, even if there's a case scenario where the child is up to date on their shots, it's still a good idea to go in every year to make sure the growth patterns and developmental milestones are being met. Okay. You're going to prep like you would, or prepare for exam like you would for an adult. But realize that when we're dealing with the infant, we will be doing a head circumference, which is not what we would do for an adult. So when we look at pediatric immunizations, this is a huge area in pediatrics for the medical assistants because this is what they will do a lot of. Not only are you doing vital signs, but you're also going to be giving out immunizations. And so every single immunization that you give out, there will be an info sheet that goes with it that you'll need to give to the parents, make sure the parents read it, and then discuss the common risks and the common possible side effects from it, and then make sure the parents understand. So those info sheets will be given out, and they'll be asking you questions because you're the go-between, okay? And so making sure that they understand what they're for, why we give immunizations, making sure that appointments are based upon that immunization schedule. You're going to have to be administering the vaccine, keeping the appropriate records for that immunization administration, and then also ensuring proper vaccine storage. And there is a little section in the book that talks about certain ones that are certain immunizations that are refrigerated and others are frozen. If something is not handled properly, it can decrease its efficacy and then not work as well. And so proper storage is huge. And so as you get into this area and start seeing it, we're not going to go through what's stored at what temperature, but as you get out there, you will have to make sure you look at the package inserts and then make sure you know what goes where. Okay. You will need to get informed consent. You'll have to explain the risks and the benefits for the shot, and every single sheet will have a vaccine information statement that goes along with it. When we're looking for, or when you're actually administering these immunizations, most of them are going to be injectable. There have been a few in the past that are nasal or oral, but for the most part, we're dealing with injectable. There's a word called contraindication. Now, contraindication is the definition of that is basically an absolute reason not to give an immunization or a medication. So there could be case scenarios where the child's had an allergic reaction to something or has a reason not to give that particular medication. If a child is immunocompromised, then you wouldn't be able to give a live attenuated vaccine to them because they might have a risk of getting it. If a child has a true egg allergy, then you can't give the flu shot. So there are certain contraindications, and so you'll have to review the sheet and review those questions with the parent. And if there is a contraindication, you'd have to make sure you alert the physician because there might be reasons occasionally where you can't give a vaccination. And this goes for medications too. We're not talking about medications here, but that word goes along with medications as well. Keeping the immunization record is huge. We have the same prototypical yellow immunization record that we've had for quite a long time. Asking the patients and requesting that they bring them in every visit is important. Keeping it up to date is as important because if the child leaves that facility or leaves the state, you don't want that poor kid to have to re-go and restart all of the immunizations. So you always want to make sure everything is up to date. There is something that we have in San Diego called the San Diego Immunization Registry, SDIR, and that is sort of a generalized immunization registry where you can input any shots given. And they've been making a huge effort over the past 10 to 15 years to start to get all physicians to use this so that way if people don't know what their record is, if they can actually check this registry. It isn't just a hospital or clinic based, it's an actual registry for the county. So that way if somebody leaves and goes someplace else, they can go, oh yeah, well I see that you were at this place and you got that vaccination. So that way we're not having to revaccinate people for things that they may have already had but don't have adequate proof of it because they've lost their immunization record. So it's possible that that may be a case scenario where input has to be made into that registry. And then anytime you use an immunization, there's usually an immunization log that you have to log into, or not log into, but that you have to write on, keeping track of what's been given. And so we already mentioned vaccine storage and handling. It is really important to make sure that you know your appropriate temperature for each vaccine. Usually it'll be listed on there. It'll tell you the temperature range that it needs to be kept at. So that's why if things come in, they usually will come in some sort of a cooler with some sort of ice or dry ice or whatever they pack it in, but it needs to make sure you can't let it sit around all day. You have to make sure that it's dealt with pretty quickly because you don't want that stock to drop in its temperature. When you prep and put things in, you're going to rotate the stock and have the immunizations that are going to expire the soonest are going to be in front, and then you're going to put the newer stuff in the back and rotate it forward so that you make sure you use everything and don't just constantly put stuff in front because you want to rotate it and make sure that you don't have stuff that expires. Okay. All right, so we're looking at the screening and diagnostic testing. The medical assistant's role is varied and wide and excessive because you're dealing with the patient from start to finish. You're doing the interview, you're doing the history, you're asking all the developmental, social, behavioral questions. You're doing vital signs and measurements. If it's a child that's 4 or 5, you would be administering vision and hearing tests. And you may have to be dealing with collecting specimens as well as administering any medications and immunizations. So it's definitely a full service job for the medical assistants when you're in the pediatric environment. Some little caveats when we're dealing with vital signs with kids. It might be better, depending on the scenario, to take the temperature last. It depends on the age, it depends on the child's temperament. And so nowadays we have the tympanic, and you can do the axillary, or even possibly that temporal scan. And so those aren't as invasive or as uncomfortable. And so if that's the case, you can sometimes take the temperature in the beginning. If it looks like the temperature is going to be an issue holding the child down, waiting till last is sometimes a good idea so it doesn't hamper getting the other signs done. So a lot of times temperature is best to wait last. It's not mandatory, but prototypically you're not going to take an oral temperature in a child less than 5. They really need to be able to hold it themselves in their mouth, and it can take 30 to 60 seconds to get the reading on an oral thermometer depending on the brand you have. So prototypically you don't. If you have a 4-year-old that can hold it, it's fine, but they do use the cutoff of 5, and that's more just because they think that a child needs to be able to hold that before using the oral one on them. Make sure you have the appropriate pediatric blood pressure cuff. The size has to be appropriate. You don't need to use the palpatory method, or it's not indicated to use a palpatory method. We kind of talked about that with adults, but you don't usually do that here. Because of their kids, sometimes the diastolic, I know you guys are still working on your blood pressures. When you're dealing with kids, sometimes the diastolic seems to go on all the way down until you run out of air. And so what you'll do is mark down the diastolic, the area where it starts to become muffled. If you hear it very distinctly and then it sounds like it's kind of muffled, but you still sort of hear it, that would be the cutoff point where it becomes muffled, which I know is kind of vague, and it takes time. You're going to have to do some frequent pediatric blood pressures to get good at this, but for some strange reason that diastolic seems to be kind of low in kids just because of their anatomy and their makeup. And so if you do have a child that it seems like it goes on forever, you'll take it where that sound starts to muffle. Body measurements are going to be done at each visit. Weight and length, or height. Length if they're laying down. Once they can stand, it's considered height. We're going to do growth charts. We'll see those. We'll talk about those a little bit. Growth charts need to be done on kids from birth until 36 months. And that includes the head circumference. All 3 of those guidelines go up. And And so we'll show how you kind of plot it, and we'll talk about the different, just what's kind of considered normal, and when children start to fall off the growth chart, or they change 2 standard deviations, that's usually kind of an indication, either height or weight or head circumference, that maybe they need to check and see what's going on with that child. So that's why accuracy of recording accuracy is important. Eye and ear exams generally start. The pediatrician does the ophthalmoscope, checking on the internal part of the eye. Visual acuity testing will start. Generally, some of them will do 3, but usually it's more prototypically 4. I warn you that kids can't always understand what needs to be done, so we do have the picture acuity ones, as opposed to trying to do the letters, because it's a little bit tough. They have the pointed E's, and then they have the picture one, and so those are usually used up until kindergarten, and then after they get older than that, you can use the normal eye chart. Ear exams too, it was the same. Remember that kind of the same as an adult. Audiometry usually starts at about 4 or 5. If you try to do it earlier than that, a lot of times they don't understand the directions. If a child that's younger, if you can't get the audiometry, you can always just say unable or uncooperative. Sometimes if there's a suspicion in a child that's uncooperative and you can't get it done, there are places, children's and some of the specialty places for ear, nose, and throat, they actually have audiology clinics, and they have soundproof rooms, and they have ways of putting the kids through a full hearing exam if they're young and you can't quite get it at the clinic. So if you're in a clinic setting and it doesn't work, but there's a suspicion, the pediatrician can usually make a referral there. If they've had repeated ear infections, if there seems to be listening issues or issues of concern, they can usually refer to that and get a full hearing evaluation done. And generally with infants and toddlers, you're still checking for these things. You'll check for responses to sound, especially. They'll usually do startle, clapping, something where you're standing or positioned behind the child and then making a noise to see if the child turns or responds. And so it's sort of it's a vaguer way to do it, but it's one of the ways that they use as far as checking for infants and toddlers when you can't actually do an audiogram on them. So different testing that might need to be done. Usually a throat culture is not going to be done on a routine, just normal healthy visit. But if a child comes in with a sore throat, a lot of times the medical assistants do get put in the position of doing these rapid strep tests. And so it can be a little bit tough with the younger kids to get them. They don't prototypically like to open their mouth. When they're younger, it's usually better to lay them on the bed as opposed to trying to sit. When they're a little bit bigger, you can have them sit, but it's usually better to lay down. The minute you do that, they have a tendency to sense that something's going to happen, and they tend to get resistant. And so if you have a child that's struggling, a lot of times what you have to do is put some gentle pressure on the nose. And I know that seems kind of mean, but we have to get the culture. 5 to 10% of sore throats are strep. The rest of them are some sort of bacteria. The rest of them are viral. But you got to know whether or not you're dealing with a streptococcal infection, because there can be disease sequelae that occur if you have a streptococcal infection. It's not treated. Scarlatina, glomerulonephritis, and rheumatic fever are all sequelae from having an untreated streptococcal infection. So it's important, and that throat culture makes the difference. And so a lot of times you get stuck with it, but a little gentle pressure on the nose, if the kids are resistant, will usually cause them to open their mouth, and then you just got to swipe quick and appropriately, because it will gag them usually. Urine specimens oftentimes have to be collected as well. When they're 4 and 5, a lot of times they can do a clean catch, or they can pee directly into the cup. There may be times where you have infants that need to get, or toddlers in diapers that you actually have to give this. So we'll show in class just how to do one of the pediatric urine catchers that you would place on the genitalia and then close the diaper up and then try to obtain the specimen that way. And then there are blood specimens that may have to be obtained. Usually at 9 months they'll do a hemoglobin, and then they'll repeat the hemoglobin at 4 to 5. And then they'll do lead levels before they enter school too. Lead's found in a number of different areas. paint chips and what have you. And since kids tend to put a lot in their mouth, they'll usually do a lead level as well. If you can't, a lot of times getting things from an artery is tough. Or I'm sorry, not an artery, a vein. No, we're not going to do any arterial sticks on these poor kids. But venous access is sometimes tough. So occasionally they can use the heel if they're younger. Hemoglobins can be done from the finger. But the heel can also be used depending on the scenario for blood draws. So realize when we're looking at diseases and disorders, even though we're going through and kind of talking about recognizing certain disease processes or asking certain questions, it isn't up to the medical assistants to make a diagnosis or even make assumptions regarding the diagnosis or treatment. It's not your place to do that. We just want to make sure that you're advocating for the patient and being a good communicator with the physician, so that if you see or hear something that could make a difference in the treatment or diagnosis of a disease process or of the child, that it's brought up, and that there's a good communication process so that any information that might be of importance is addressed. So realize that you don't have to make those diagnoses, but any information that you can obtain, just making sure you share that with the clinician. If there is a high fever, and high fevers will vary, a lot of clinics will have a certain specific protocol. If the parent complains of a specific fever, if it's high enough, a lot of times they'll send them to the emergency room. If it's sort of mild to moderate, they'll usually try to schedule an appointment with either that day or the next day so that the child can be evaluated. If it's done with one of the forehead strips, they'll sometimes ask if it's possible to take a different method, because those can be a little bit off. But any high fever, notify the physician so they can give you guidance on what to do. We don't ever give aspirin for children that have fevers. Now, aspirin, you don't see too much liquid aspirin out there. We usually use baby aspirin for adults that have cardiovascular disease as an antiplatelet treatment. But a long time ago, aspirin it was the cheapest medicine out there. But the disease process called Rice syndrome came occasionally with children that had high fever, so we don't give aspirin anymore. Tylenol is usually preferred, acetaminophen. If you go to Children's, that's all they give for fevers. It is possible to give an anti-inflammatory, an NSAID like Advil, ibuprofen, or Motrin. Children's Hospital doesn't like to give that because it's sort of in the same family as aspirin, although it's not the same medication. There can be stomach upset from the NSAIDs, and so that's why Children's veers from using them. But as a parent, I found that those worked much better than Tylenol. They work quicker and they last longer because you can give it every 6 to 8 hours as opposed to Tylenol, which is every 4. And so I have to be honest with you, I did use ibuprofen quite a bit when my kids were little, but it can cause stomach upset, and you will find some places that prefer not to use it because of that, and will use Tylenol as an alternative. So some common diseases and disorders that will be seen: head lice and impetigo, infectious conjunctivitis, which is pink eye, and streptococcal sore throats are probably the most common on this list here. And the book kind of talks about what you'd find and a little bit of the treatment regimens of these. Herpes simplex virus, which is basically like is a viral infection, and it can sometimes affect even infants. You can get a aphthous stomatitis, where they actually get these little ulcers in the gum line. It doesn't happen a lot, but when it's there, it can be pretty significant. The kids just don't want to eat or drink, and they're very miserable. It's not as common as some of these other things, but it is there. Impetigo is actually kind of common. I don't know if I put that in the top, but it's a very contagious bacterial rash that generally occurs around the nose and mouth because the kids have a lot of runny nose and they pick and they scratch. Those areas where the skin integrity is disrupted, they can get bacterial infections set in, strep or staph can set in, and so it can be very contagious. They get these little honey-crusted areas, and so they must get on some form of antibiotics to treat that. Otherwise, it can continue to spread. Infectious conjunctivitis is pink eye. You can also have viral conjunctivitis, but if it's infectious, it's generally bacterial. These kids oftentimes will be sent from school with a pink eye, and they have to be evaluated. It is very contagious. but generally eye ointment or eye drops, antibiotic eye drops, can take care of it in a few days. They generally have to be on medicine for 24 hours before they can go back to school. Same thing with streptococcal sore throat. I mentioned that already. It's important to take antibiotics for a streptococcal sore throat, so they are utilizing rapid streps quite frequently in the urgent care and primary care. If the culture is negative, or if that rapid strep is negative, they'll send an actual culture to the lab that'll grow out in 48 hours, and they'll be able to tell for sure. So if it's positive, a lot of times they won't send the throat culture, but if it's negative, they'll send it, and then they'll let the patient know that, hey, we're going to send this off, and we'll give you a call in 2 days if we need to get you antibiotics. If you don't hear from us, then it was viral, and it should be gone within 2 to 3 days. Pinworms, we don't see that often. Those are actually little worms that like to reside at the opening of the rectum. It does happen sometimes when people come in complaining of rectal itching. That can be the source of it, and they do something called the tape test, and then they look at those little guys underneath the microscope to make the diagnosis. Ringworm is a fungus, and that's actually kind of common. It's in the same family as jock itch or athlete's foot. And so generally when they come in with that, it can be passed on the dander of animals, cats and dogs, but there's some topical creams that can take care of the ringworm. The next set of slides are pretty much straight from the book, and they just kind of give kind of a quick little synopsis of the signs and symptoms that you would see. I think there's, 1, 2, 3, 4, 5, 7, 8, 9 or 10 of these. What I would just try to go through and do is memorize 1 or 2 sentences from each of these. Some of these you probably are familiar with already. They are kind of distinctly different, so if you were given a description of it, they're fairly different and should be fairly easy to remember. Keys with AIDS, when we're looking at HIV positive children, most of the time it's from a vertical transmission. Vertical means transmitted from mother to child through the placenta during pregnancy. Getting these patients, or the pregnant females that are HIV positive, and knowing their status, that's one of the things that's usually included in a prenatal panel, is to check for HIV, so that if something is detected, they can actually get that mother on AZT as soon as possible. You can decrease the risk of transmission. The risk of transmission is 25 to 30%, somewhere in there. Without AZT, with ACT, it's about 3 to 4%. So it decreases it below 5%. So getting those patients on AZT really drastically decreases the risk of passing that virus on. JRA is juvenile rheumatoid arthritis. This is an autoimmune disease that we normally, when we see rheumatoid arthritis, that's adults, but there is a juvenile form of it that can hit kids, and that's children that are under 16. And it can be just like adults. The severity can be mild to severe. It can affect eyes and internal organs, as well as the connective tissue and joints. And so it can be devastating enough in adulthood, but when these kids wind up with it, it's a long battle, and they can go through periods of remissions and flare-ups. But it's a very difficult disease to deal with, and so we don't see it a whole lot, luckily, but it definitely is there. And so these kids' lives are impacted when they contract, or when they wind up coming down with this particular autoimmune infection. ADHD and learning disabilities, you could also put ADD in this category as well, which is ADHD is attention deficit and hyperactive disorder. ADD is just attention deficit disorder. They tend to present similarly in that they have difficulty paying attention, they have focusing issues, they have learning disabilities. The H part indicates that the ADHD children generally are hyperkinetic or hyperactive, and so they tend to be the ones that are bouncing off the walls. The ADD kids are sometimes a little bit more difficult to identify because they're not generally hyperactive. They're just kind of quiet and reserved. But they can have some learning issues. And so there's a wide range that can interfere and cause problems. And I think the book kind of describes ADHD as being sort of the most underdiagnosed. Let me see if I can find the exact words that it talks about. It says it is the most misunderstood, misdiagnosed, and then overdiagnosed as well, because um, physicians have a tendency, or teachers will sometimes have a tendency to think that every hyperactive child or every overactive child has ADHD, and then other doctors are afraid to label kids, and so it's definitely a conundrum when coming up with this diagnosis. But it is a cohort it's a team environment when you involve the teacher, the parent, and the physician to try to make sure that if the child is identified as this, that they're actually treated accordingly and they get the help that they need, because they can have lifelong learning issues, and they can get very behind in school. And by the time they maybe quote unquote start to calm down a little bit when they hit middle and high school, they could have missed so much when they're young, that it can seriously affect their learning process as they go through school. So making sure that it is adequately diagnosed and appropriately diagnosed, and that if medication is indicated, that there's times where it needs to be considered. And so I know there's a lot of discrepancy and a lot of discord over using these medicines, but sometimes it can be the right thing to do and sometimes it's not. So just making sure that everyone is open to the possibility and got good communication lines between all three parties is important. CP, we don't see that a lot, but it is still there. It is a birth-related disorder to the nerves and the muscles. It usually causes some sort of brain damage either before or during the childbirth process. It used to be a common occurrence with using forceps, so they stopped using forceps, but there can be other traumatic birth issues, shoulder dystocia, what have you. If there's some sort of brain issue that occurs during that time frame, then it can then lead to muscular issues after the baby is born. It isn't a progressive disease. Whatever issue is present, once the baby is born, it usually stays that way. It's not something that progressively gets worse, so it isn't considered a progressive, but it is a muscular issue that can affect not only the walking, but also vocal birth or vocality and speaking and what have you can be affected as well. There's a number of congenital heart diseases. I'm not going to go through all of them, but there's a number of different things that can lead to them. Maternal insulin-dependent diabetes can be an issue with that. And I'm going to change that to maternal. So there's a number of different ones. Luckily, they aren't seen that often, but these kids are almost always seen in concert with a surgeon or a cardiologist, if that's the case scenario. Down syndrome is a genetic disorder due to an extra chromosome at the 21 spot, so that's why it's called trisomy 21. They are very prototypical facial features and fetal development issues that are very similar in all Down syndrome children. But when their intelligence levels can vary greatly, and so there's a lot of Down syndrome individuals that wind up being able to hold jobs and going to school and getting a college degree. And so there's definitely been a lot of work done promoting keeping these kids as involved as possible with sports, whatever they're capable of doing. And a lot of them are growing to have very fulfilling lives. So Hep B, we don't see too much because of vaccination, and we always do a hepatitis B titer during the prenatal panel, and so we kind of know where the mother's status is. Hep C is one thing that we don't actually routinely check for, and that it's starting to become a little bit of an issue, but it's not drawn in tandem with the hepatitis B unless there's a history of it. And we don't have any vaccinations for Hep C, although we do have some new medication that is working to eradicate it. RSV is actually a respiratory virus, respiratory syncytial virus, which is a major cause of pneumonia, bronchiolitis, and croup. It is very, very contagious, but it's hard to treat because no antibiotics will work unless there's a secondary infection. So these kids oftentimes have to be on some sort of humidifier or racemic epinephrine given in a humidifier. Oftentimes medicines that we'd use for asthmatics we'll use here to try to decrease the inflammation. And so that tends to be a common virus that has to be dealt with. It can be kind of tough, once again, because there's no antibiotics that treat it. We do see it more in winter months, but also the spring. And so it's just important to try and, if you know if a child has been diagnosed with it, just try to keep those children away, just because it is kind of a tough virus to deal with. SIDS is sudden infant death syndrome, and there is a pretty good paragraph on there that talks about SIDS. It is unexplained sudden death of an infant during sleep. It can happen anywhere from birth to 6 months, but 2 to 4 seems to be the more common age area for it, or age range. Prototypically, we don't want kids sleeping on their sides of their stomachs. We want them sleeping on their back. When they don't want to sleep in adult bed. You want to make sure that they are in a crib environment, that there's no big blankets, no bumpers, no squishy toys. They really need to have small, light blankets. And there's other risk factors too that talk about the age of the parent, lack of finances, smoking in the house. So there's a number of different things that do increase the risk of SIDS. And so this is oftentimes in part of the developmental stuff, is the every age group has got certain guidelines, safety guidelines that are given to the parent after the parent, or usually at the exiting part of the exam. And so these are some of the questions and some of the things to watch out for with giving to the 0 to 4 and 6 month range will involve things to prevent SIDS. Okay. And then I'm going to skip over spina bifida, but viral gastritis is basically, that's the stomach flu. And so it's something to look out for. Kids do tend to be a little bit more prone to it, and obviously they can dehydrate much quicker. And so it is just one of those illnesses that we do see pretty frequently. It could be bacterial, like a Salmonella, Shigella, or it could just be a straight virus. This one, viral, indicates that it's virally mediated and not a bacteria. And so we look at the pediatric special concerns that we kind of look at the end. The things that we deal with in this area are detecting child abuse or neglect, eating disorders, the risk of suicide, depression, and anxiety. And so these are different things that we might want to chalk up to being something that's more psychologic, and it is, but it has to be dealt with in this age, or during a physical exam. And even though they're more mental associated things, we still have to address it at a physical exam time frame. And so a lot of the questions when you deal with 14 and 19-year-olds will revolve around these kinds of questions, as far as eating disorders and suicide, depression, anxiety. A lot of the questions will say that, are you being bullied? Do you feel sad? Or do you have thoughts of wanting to kill yourself? And trying to identify kids that are high risk for these things will go into that age group specifically. Okay, so the first thing that's on this list is child abuse or neglect. And so it's really important to watch for these things with each interaction, each caregiver and child. You have to watch that relationship. If there's a lot of animosity, screaming, yelling, if the parent's yelling at the child repeatedly, smacking them, those are things to look for. And if you see anything that seems like it could be an issue, alerting the clinician is important. Okay. We're in a situation where we are reporters, and we have to report any suspected abuse. It doesn't have to be 100% validated. In just the thought or the suspicion that someone is being abused, we have to report. And so it's important, if you pick up on anything or see anything that maybe the clinician might not see, because you have a lot of, you spend more than half the time with the parent and the child, or the caregiver of the child, bringing that immediately to the attention of the clinician is important, so that the clinician can look for those things and deal with it. And so looking for physical injuries, any signs of neglect, poor dentition, hair's not combed, poor, dirt under the nails, just things that might indicate that the child could be either neglected or being injured. Make sure that you report it immediately to the clinician. Okay, the clinician then will examine for these things. Is there any signs of internal injuries or nutrition, or sometimes if they're apathetic and they don't actually reach the developmental milestones, it could be because they're not given the proper attention that they need at home. And so those are things that physician will check for. There's a number of risk factors: stress and financial issues, a single parent. There's a host of 6 or 7 things that they talk about in the book. And so those are all risk factors. And identifying these risk factors and getting these people help, intervention does make a difference, because then they start, when they're given, it doesn't help everybody, but it has been shown to help a lot of people. So when we can get these people identified and get them the appropriate help, it can decrease the risk of having this continue. Okay, but once again, the abuse and the neglect must be reported by law. And so if we suspect something, we don't have to have absolute proof. We must report. Okay. Other questions that we kind of look at are eating disorders. Once again, these aren't necessarily physical per se, but they'll have physical repercussions over time, especially anorexia nervosa. And so screening males can be anorexic and bulimic, but prototypically it is females predominantly that have these 2 illnesses. And once again, when you're in that 14 to 19 age range, there's a lot of stress to be thin, a lot of stress to be perfect. And so certain people will be at higher risk for developing this. And once again, they can both have lifelong repercussions for both of these illnesses. So if we can identify people that, that are, anorexia nervosa, if somebody comes in and they're under the 18th BMI percentile, bulimics sometimes have poor dentition. They'll have scars on their knuckles from from inducing vomiting. So looking for little things like that can sometimes bring these disorders to light. Depression, substance abuse, and addiction are all things that need to be addressed in that 14 to 19 range as well. They can sometimes be coexisting together, and they can be difficult to tell apart because they can show a lot of the same symptoms. When kids start to, when they start losing interest in things that they normally were interested in, if their grades drop, if they have anger, bursts of anger, if they withdraw and they don't talk, they could be experience one or all of these things. And so it's really important to ask the appropriate developmental questions, and the family, both the patient and the family, if there's any issues going on with this. Suicide is something that we've had too many kids. It's the leading cause of, I think it's the 3rd leading cause of death from the 15 to 20 range. And so I'm not sure I got the exact age right with that, but, and so it's important to not ignore signs. If someone is threatening it or talking about it, or even, you have to take it seriously. I know sometimes people think they're just trying to get attention, but if they're saying that to get attention, then they probably need the attention, and it's important to try and figure out what's going on. And so looking for those warning signs are important, and we don't ignore a threat, even if somebody says, oh, they're just joking. There's got to be a reason why they're saying those things. And we kind of already mentioned this too, but making sure that age group 14 to 19 that sexually transmitted infections are discussed. Possible birth control information is discussed and made available. I know a lot of people preach abstinence. There's nothing wrong with that, but kids need to at least know what the availability is, so that if something is going to occur sexually, that the kids are protecting themselves. Okay. And so I know there's a lot of things. A lot of parents don't like to talk about these things. They feel uncomfortable. But it is better to open the lines of communication so the kids can at least feel comfortable coming to talk to the parents, and then knowing that there are places out there, there are clinics out there that can help them if they have questions or need anything. Okay, so we covered a lot. I think I lectured a little bit longer than I had intended. So we looked at kind of the growth and the developmental stages, pretty much from birth until 18. Going through all of the school age arenas. And so we looked at each one of those areas. And like I said, a lot of the questions that medical assistants will deal with and ask are through those particular 4 areas. And so once again, you don't have to memorize them. Just being kind of familiar with the age groups will help. Okay. Just more importantly out of this, realizing that you have to be able to learn how to communicate not only with the pediatric patients, but as well as the parents. And you are going to be an advocate and a mediator between the parents, the kids, and the physician. And so you're going to spend the most time with them. And so getting familiar and comfortable with all of these things and um, be able to perform all of these tests competently and quickly, and being able to maintain conversation and being able to make both the parents and the kids feel comfortable. It'll make the experience a lot, make everything flow smoother and make the experience a lot better for the parents and the kids. Immunizations are just a part of life, and it's tough. I know it's hard. A lot of people don't like to go into pediatrics specifically because they have to give so many immunizations, but the immunizations are there to protect the children. And so um, our 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 lab time isn't going to really cover shots with kids because of the fact that we don't have kids and we aren't practicing on kids. You guys will eventually give immunizations to each other. And so when you go into pediatrics, a lot of times they'll use the left upper outer thigh when they're giving shots when they're little. It's not till they're 4 or 5 that they actually start using the upper arm. And so the buttocks the gluteal area can be used as well. But becoming familiar with these, like I said, I put a immunization schedule on Canvas so you guys can print up. It is last year's, but at least it gives you an idea of the scheduling that's available. And then realizing your responsibilities that revolve around that is important, as well as the storage and handling of the immunizations. Okay. Getting comfortable with hearing tests and visual acuities is going to be important because pediatric patients are tough. Some kids can do it at 4, and sometimes you got an almost 6-year-old that struggles. And so you just have to realize that all kids are different. Don't get frustrated. If you need help, ask for help. But the more you do it, the easier it'll get. Okay. So I'm going to go ahead and stop here, and we'll cover some different things in class. We'll go through and measure a mannequin infant and go through the head circumference and the length and the weight. We'll put on a little urine bag, and we'll go through and do some, try to think of what else we do. I'll have some stuff related to the gynecology. I know we're not talking about that here, but we'll definitely go through the infant stuff in class, and then we will carry on from there. So I'm going to sign off here, and I'll see you guys in class.